Welcome to APMA Online CECH. I'm Dr. Diane Tower, APMA Director of Clinical Affairs, and I'll be your moderator this evening. APMA is pleased to offer its members free continuing education contact hours, or CECH, on a variety of topics. This live webinar will be recorded and is provided complimentary exclusively for APMA members. This is week 7, the final week of this current series, and we are going to hear about current treatment options for heel pain, including platelet-rich plasma, biologics, and extracorporeal shockwave therapy. APMA has approved this activity for 0.5 CECH, and no commercial interest provided financial support for this continuing education activity. Next slide, please. We will have a few minutes at the end of this evening's webinar to address questions. So if you have questions throughout, please type them in the questions box in the GoToWebinar toolbar. We will address as many questions as we can in our allotted time and apologize in advance if we can't get to all of them. I want to introduce our speaker and get right to the presentation. Today we have Dr. Priya Parthasarathy, podiatrist with the Foot and Ankle Specialists of the Mid-Atlantic, Chair of the APMA Communications Committee, and Secretary of the Maryland Podiatric Medical Association. Dr. Parthasarathy has no relevant financial relationships related to this webinar to disclose. And I'll hand it over to you, Dr. Parthasarathy.
Thanks, Diane. Thank you so much for having me. I feel so privileged to be able to speak to so many of you. This is going to be a walk down memory lane. We're going to go through some etiologies of plantar fasciitis. We're going to specifically concentrate on regenerative medicine. So, brief introduction. Plantar fasciitis affects about 1/3 of the world's population. Recalcitrant cases are very difficult to manage, as we know in our offices. And recent studies are validating newer, more conservative treatment options. This is one of our most commonly treated conditions in the office. So 89 to 90% usually resolve by treating conservatively using traditional methods. We as podiatrists should be at the forefront of treatment. We should always keep reevaluating our protocols and treatment plans to keep current with the current literature. So again, today we'll concentrate on non-traditional conservative options, specifically regenerative medicine. So I'm going to go through some relative anatomy for PRP, electric shockwave therapy, as well as amnion injections. So the calcaneal fat pad is made of microchambers, which are smaller, superficial, and they have little deformation forces. The macrochambers are larger, deep, with significant deformation under loading. And these are majorly responsible for compressibility and mechanical properties of the heel pad. So studies show that the heel pad is found to slowly lose its elasticity and energy dissipating properties as a shock absorber due to age, obesity, and diabetic conditions. So fat pad atrophy and reduced shock absorption in the heel is observed to have a strong connection with severe heel pain and diabetic ulceration. So the relative anatomy of the plantar fascia. So we all know that it connects with the Achilles tendon, and it inserts through slips into the plantar plate, flexor tendon sheaths, and the bases of the proximal phalanx. So according to some study authors, the embryological origin of the plantar fascia sees it united with the Achilles tendon. So this connection is made of a layer of periosteal fibers that declines in thickness and elastic properties with aging. So that's why many of our rehabilitation protocols recommend considering the Achilles and the triceps surae muscle in rehabilitation treatments for plantar fasciitis. So it's important to remember the thickness and elastic properties, because we may be able to recreate some of this with amnion injections, which we will later discuss. So what's it made of? Type 1 collagen, which is mostly arranged in a longitudinal direction. So plantar fasciitis causes a disorientation of these fibers. So it's full of mechanoreceptors and proprioceptors, and there's high levels of hyaluronin, proximally especially. And this gives an implication for amnion or hyaluronic acid injections. Because the plantar fascia actually has more fibroblasts than do tendons, It's believed that it has an even greater sensory capacity than tendons. So it may have an active sensory structure by changing its composition to passively transmit forces. So the body uses the plantar fascia to assist with balance, positioning, and gait. So there's a lot going on with the anatomy, with the forces, and of course, we can't forget the windlass effect. So I just put this diagram up there because we all know what the windlass effect is and how important it is to biomechanics and plantar fasciitis, but I want to show this diagram to just remember the magnitude of forces acting on the tendon itself. So what are common causes of heel pain? So we know Achilles tendonitis, bone tumors, bursitis, Haglund's deformity, Paget's disease of bone, plantar fasciitis, reactive arthritis, bursitis, rheumatoid arthritis, sarcoidosis, stress fractures, and tarsal tunnel. So again, it's very important to decipher what the true etiology of heel pain is and to make sure there aren't any extrinsic factors in play. So not all heel pain is automatically plantar fasciitis. So yes, we all know what causes it, right? But do we actually know what causes plantar fasciitis? Now, this is a very interesting diagram. So it highlights our current thinking of plantar fasciitis. So historically, we think that intrinsic factors such as age, heel pad, foot type, and motion are the principal causes of plantar fasciitis. And then you combine that with an exposure to extrinsic risk factors, right? Like footwear and increased walking, change in activity. But there's actually little scientific data to support this argument. So studies suggest that many parameters traditionally considered risk factors for plantar fasciitis are not actually risk factors. They're instead likely aggravating factors that do not influence the risk of developing the condition, but it varies the level of heel pain once it is present. So this is what we should be thinking. So this is a very interesting algorithm, reassessing potential deficits as etiologies for plantar fasciitis. So they're looking at it as a neuromuscular deficit with the normal fascia versus a material deficit of plantar fascia. So there's an abnormal fascia. So there's two mechanisms. Some studies actually show thickening of bilateral plantar fascia, although only one side is symptomatic. So that could suggest that plantar fasciitis is actually a systemic process. The mechanism points to it being more of a micro damage to the plantar fascia, which results in degenerative changes. So what this algorithm is saying is one mechanism is the damage is done when the plantar fascia has abnormal stresses bilaterally. The second mechanism is there's actually an inherent deficit already in the plantar fascia, and when it can't tolerate the stresses, and you pair that with extrinsic factors like poor shoe gear, new activity, the plantar fascia is unable to remodel itself. And that's exceeded, which results in that micro damage and continues the degenerative changes happening. So we usually think of plantar fasciitis as this acute inflammation process instead of possibly it being a degenerative process. So the diagnosis. So the clinical exam is a cornerstone of plantar fasciitis diagnosis in our office, of course. But it's also important to consider X-ray, ultrasound, and MRI. Ultrasound is a technique that's very valuable, especially with regenerative treatment methods that we're going to discuss. So it can show thickening or tears of the plantar fascia, stress fractures, soft tissue tumors, and it is more cost effective than an MRI. So ultrasound is a good alternative for patients with out-of-pocket costs. So this diagram highlights the white arrowheads on top shows edema within the bone. And then the bottom picture, the black arrowheads show hypervascular changes in subcutaneous tissue. And this demonstrates stress injury and inflammation. So What's important to note is hypervascular changes, like the one seen in the bottom diagram, are seen in patients without inflammation, but it's always present with patients who have plantar fasciitis. So it is a good indicator that plantar fasciitis is there. It's also important to order those x-rays and MRIs when needed, because stress injuries or calcaneal edema, all of these etiologies of plantar fasciitis or diagnostic markers that we see could lead us down a different treatment protocol, which could result in fracture boots, immobilizing, subchondroplasties. That's a whole other presentation, but very important to use these diagnostic tools that we have available to us. So what are our traditional treatments? We all know stretching, physical therapy, night splints, strapping, taping, orthotics, shoe gear, and NSAIDs. And they all are first-line treatments, and a lot of them work. So these are the usual treatments that we do on the first few visits, and they work about 90% of the time, we hope. More of our practices are going towards more protocol-based treatments, especially with ankle sprains and plantar fasciitis. It's great to have protocols, but it's very important to tailor it to the patient's needs. For example, if your patient has pes planus and plantar fasciitis, of course, orthotics may work, but if they're limping around and cannot weight bear, we may need to bring in a fracture boot. But if there's changes in the ultrasound or things are pointing towards a thickened plantar fascia, you may be able to bring some of these regenerative treatment options into the mix a lot sooner. Of course, some of our other treatments are steroid injections and oral steroids. So steroid injections, we're going to be looking at that in detail because a lot of these studies compare these regenerative treatments to steroid injections. So there's always a risk of tendon rupture, and there's questionable long-term benefits, as we will see. And it could result in fat pad atrophy. So it's always important to consider if a steroid injection is necessary. So the more conservative options that we're going to discuss are new evidence-based medicine, resulting in platelet-rich plasma injections, electric shockwave therapy, or EPAT, which is a form of shockwave therapy, as well as amniotic injections. So first, we need to identify the chronicity. So the 2018 APFAS Heel Pain Clinical Consensus Statement chose chronicity as a way to help identify appropriate treatment plans. So it's important to look at acute at 4 to 6 weeks, subacute 6 to 12 weeks, as well as chronic, which is greater than 3 months. So chronic heel pain, important to consider that the pathology may be related to something else, such as bone, nerve, or soft tissue. So it's very important to rule out tarsal tunnel with possible EMG and nerve conduction studies for chronic patients, as well as Baxter's neuritis, and all the other differential treatments. So we will examine when to initiate the treatment option and at what time. Platelet-rich plasma. Why is it so good? So it has high levels of growth factors and anti-inflammatory cytokines, stimulating cell migration, cell proliferation, angiogenesis, and matrix synthesis. And there's no known adverse effects on the plantar fascia itself. So what PRP does is it basically reorganizes the collagen fibers and increases the vascularization to the tissues. So looking back at our etiology algorithm, if plantar fasciitis is a degenerative process, using PRP makes sense. So things to consider. The product varies per supplier. So that makes consistent research difficult because in a lot of these studies, they've prepared it differently. So it's not the same in each one. And there's no consensus on preparation. So it can be activated by addition of either calcium chloride or thrombin, and costs can vary from $500 to $2,000. So make sure whoever you use has the studies to back them up, whatever company that you decide to go with for your PRP. So these activation components, they cause the platelets to aggregate and they release the growth factors. So Most of the research is based on leukocyte-rich PRP, which seems to be the way to go. But again, every vendor prepares theirs differently. So the leukocyte-rich actually has a higher concentration of neutrophils at baseline. So how do we use it? Usually 1 to 2 injections a month apart, and it's typically injected in chronic, but can be used in acute or subacute. So it seems to have this analgesic effect, which the mechanism is unclear on how that happens exactly. There is a decrease in tendon thickness, and it also realigns those collagen fibers that have been malaligned with plantar fasciitis. And looking at some studies, there appears to be some lasting benefit for at least a year. So our first study looks at PRP versus corticosteroids for plantar fasciitis. And so this is a level 1 study, and they use the VAS pain score and the AOFAS scores, and they compare the groups at 1, 1.5, 3, 6, and 12 months where possible. So a total of 9 retrospective clinical trials were identified comparing 239 patients with PRP and 240 patients with corticosteroid injections. At the follow-up, there was a statistically significant difference in the VAS scores in favor of PRP. So this was seen particularly at the 12 and 6-month follow-ups. So there was a reduction in plantar fasciitis pain, and also the functional outcome scores were increased at 12 months. So some limitations of the study: the follow-up of the studies were short, and only 2 studies evaluated the outcomes at a 1-year follow-up. So finally, there was no placebo control group, which would be important to evaluate in a pathology that is often self-resolving. So the next study on PRP, again, compares corticosteroids and platelet-rich plasma for the treatment of chronic plantar fasciitis. This is a level 2 prospective study of 40 patients, so it is a small patient size, who have not responded to conservative treatment for at least 6 months. So definitely they're looking at that chronic phase. So the first group had 2 injections of PRP, and the second group was injected with methylprednisolone. So the PRP group decreased the thickness of the tendon more so than the corticosteroid group and maintained the decrease for a longer period of time. So they evaluated it through imaging with planar ultrasound at 3 and 6 months and MRI after 6 months. In the imaging test, the PRP group, the thickness of the plantar fascia changed from 7.9 to 4.8 over 3 months, and it maintained its thickness at the 2 following follow-ups. In the second group, with the corticosteroid injections, the change was 8 to 6 millimeter, the thickness of the plantar fascia, but then it increased back up to 7 almost after 6 months. So this may pose the argument that maybe PRP should be initiated earlier, as we do with corticosteroid injections, because we want the decreased thickness of the plantar fascia to help in healing and biomechanics as well. And it appears that the PRP and corticosteroids also have the same acute benefits, but PRP appears to have better long-term results. Next, we'll look at shockwave therapy. So it's developed in Europe and it's considered a standard of care in most of the world for treating chronic musculoskeletal conditions. So EPAT is a very popular machine, and it's a form of extracorporeal shockwave therapy. So how does it work? There's acoustic waves with high energy peaks, and they interact with the tissue, causing the effects of accelerated tissue repair, cell growth, analgesia, and mobility restoration. So how to do it? In the chronic phase, but can also be used for acute and subacute. And there's 3 to 5 shockwave treatments every 5 to 7 days. No icing or NSAIDs. So the first study is a level 1 trial, 250 subjects, and the subjects had shockwave therapy or a placebo intervention with 3 sessions at weekly intervals. And they saw that there was a decrease in pain at a 12-week follow-up. and a 34% decrease in the placebo group. So the authors here concluded that using shockwave therapy applied in weekly interventions without local anesthetic demonstrated relevant clinical effectiveness in the treatment of chronic plantar fasciitis. But what was interesting is that roughly 30% of the placebo-controlled group also obtained relief. This may be the placebo effect, or that plantar fasciitis may be self-resolving in some cases. So the next study looked at 72 patients with unilateral plantar fasciitis, and they used shockwave versus a betamethasone injection. So researchers found that the radial shockwave patients experienced significant improvements in measures such as the VAS score, foot function index, heel tenderness, and plantar fascia thickness, and maintained these improvements at follow-up exams. But in comparison, the study notes that the patients in the steroid group saw improvements in the same measures, but did not maintain the improvements during follow-up at 1, 3, and 6 months. One thing to remember about shockwave therapy is a disadvantage is that patients may take up to 12 weeks to see results, because the main beneficial effects of the treatment is actually development of new blood vessels, which takes time to happen. And there are numerous studies that back up shockwave therapy and plantar fasciitis from 2003 to 2010, but these are the two most recent ones. Now, last, we're looking at amnion injections. What is it? So it's comprised of mesenchymal stem cells. It contains collagens types 3, 4, 5, and 7, fibronectin, and laminin mesenchymal cells. It contains fibroblasts, which we know the plantar fascia is composed of, growth factors, hyaluronic acid, as well as antibacterial properties, and it's easily obtainable. So it facilitates in tissue healing and wound repair. Bone marrow aspirate does this as well, but it requires a surgical procedure and possible anesthesia. So how do we do it? Typically in the chronic phase, same as PRP, 1 to 2 injections a month apart, and ultrasound guidance shows better results. Avoid ice and NSAIDs. So this small study with 44 patients between ages of 55 and 47 had plantar fasciitis and Achilles tendinosis, and they were unresponsive to multiple therapies at a minimum of 6 months, which again puts them in the chronic phase, and they were treated with 1 amnion injection. So they saw significant improvements in the VAS score in all patients. So pre-injection, the average was 8.2, and by post-injection, week 4, this pain score was 5.2. And at 10 weeks, the pain score was an average of 1 to 3. This pilot study, which is a level 1 trial, had 23 patients, which again is a low number. But it did show that there was no statistical difference between the groups. And so here they were looking at the cryopreserved human amniotic membrane versus corticosteroid injection again. So no significant difference in the short term, but the 18-week follow-up demonstrates a higher FHSQ foot pain improvement. So this is a pilot study and requires further investigation, but it does demonstrate that amniotic membrane injections could be a safe alternative that may have better long-term outcomes again, but similar short-term effects such as corticosteroid has. So what did we learn from all of this? So we went down memory lane, refreshing our memories on the etiologies of heel pain, and we really concentrated on these 3 regenerative treatments that you could add to your practice. So we need to better understand the cause and effect relationship with plantar fasciitis. So we need to change our thinking that plantar fasciitis may be a degenerative condition. So we have to approach our treatment protocols differently. New evidence-based research shows PRP, amnion injections, and extracorporeal shockwave therapy have more long-term effectiveness than cortisone injections. And they seem to have it seems to be safer than cortisone injections too. You don't have to worry about the fat pad atrophy or the risk of plantar fascia rupture. So it appears that the future of treatment, especially for chronic conditions of plantar fasciitis, is regenerative medicine. Now, what's the downside? Of course, it's not covered by insurance in a lot of cases, and so it's going to be an out-of-pocket cost for your patient. But again, with the less adverse effects of corticosteroids, we may need to start turning to regenerative medicine sooner than we have, because we seem to implement the corticosteroid injections much earlier in our treatment protocol. Now, important to remember that longer follow-up past 1 year is needed to see the true effects. So does the plantar fasciitis come back? Does the tendon continue to thicken? So further research is needed, but definitely regenerative medicine is something that I feel is very important in the treatment for plantar fasciitis and really important to add to your practice. Thank you so much. I hope this was enjoyable for you and you got to learn something that you can put into clinical practice right away.
Thank you so much, Dr. P. We do have a few minutes for Q&A, but before our first question, I'd like to note that the link for this evening's evaluation has been shared in the questions box in the GoToWebinar toolbar, and it will also be shared with attendees via email. You must complete the evaluation in order to be eligible for CECH, and you will have through June 21st to complete the evaluation for this evening's webinar. Certificates will be sent via email to the email address you used to register for today's event within the next 2 to 3 weeks. We'll start with the first question here. We have someone, in my practice, we've been hearing or seeing many more patients with heel pain since the COVID-19 pandemic, as more and more people are either at home wearing no shoes or unsupportive shoes, or are exercising more because there isn't much else for them to do. How are you dealing with this and sharing information with your patients while they're in stay-at-home or quarantine?
Great question. So this actually leads into, I added one more slide into my presentation as chair of the communications committee. Right now, we are rolling out information about plantar fasciitis to the public. We were going to originally do this in our spring campaign, but we put that on hold for COVID. So the current campaign is being rolled out. So today's podiatrist is your plantar fasciitis expert. So we have tons of materials for you to share with your patients, posters, footprints, social media. And this isn't just for this month. It's year round and it's always available for you. And the increase in heel pain is something I'm definitely seeing in my office. People are not wearing shoes. They're also trying new exercise regimens, such as running, and they don't have the right shoes on. So going back to the basics, and I think that's why this webinar was important. Although it's something that we treat all the time, it's really important to go back and review the mechanisms so we have newer treatment protocols that we can offer to our patients. I hope that answered that question.
Great, and we also have our APMA Director of Communications, Ms. Peggy Tresky, on the webinar with us this evening. If there's any additional information you'd like to share.
Thanks, Dr. Tower. I think Dr. Parthasarathy covered it beautifully. This is a campaign with rich resources, and we didn't have the opportunity to roll it out in April for Foot Health Awareness Month, so we're eager to have the membership use these materials. As Dr. Parthasarathy said, they will be there year-round, and I would encourage everybody to also, sort of make use of them in conjunction with all of the materials that we have at our COVID-19 site for reopening practices. There are lots of materials there to kind of help your patients get a little bit more comfortable with coming back out and seeking the medical attention that they may need as a result of any injuries or poor footwear choices. So good options on the website. Thank you.
Thanks so much. Dr. P, we have a couple of questions here related to amnion, so I'm going to try to group those together. Can you talk a little bit about the cost to the physician, the cost to the patient, and what it's like having that around? Does it need to be refrigerated? What's the shelf life? And is it a multi-dose vial? If you have any information on amnion.
So there is a lot of different companies that are carrying amnion right now, and I can tell you that it's definitely more expensive than PRP. I've used PRP a lot and avoided surgery in a lot of my patients. They've actually come to me, they've been told that they need surgery, and I've been surprised how well PRP has worked. Amnion is a little bit of a harder sell to patients because you're looking at a higher cost. And so that's a little difficult. They need about 1 to 2 injections, and the cost varies between, you know, I don't even think we've done it for as low as 500, but anywhere from, you know, 800 to about $2,000. So it is more expensive, and the shelf life and things like that. It depends how you what provider that you use, and if you buy it in bulk or not, you know, if there's other practices that are using it. So unfortunately, I can't give specifics on that, but I can share, if anyone is interested, the companies that we use, and direct you in the right direction.
That's wonderful. Thank you. I think we'll have time for one more group of questions, some similar questions, but about PRP this time, Dr. P. What's the cost of PRP? How do you obtain it? And can you talk a little bit about whether it's done in the office setting, the OR setting, in terms of patients' level of comfort during that injection?
So this is a great question. I was going to add a little, you know, a little story about residency and how we used to put PRP on everything. I think I've been out of residency for about 10 years now, but it was used a lot more in the OR. That I remember a lot of my attendings were using it then, but now it's not covered. And so I have actually only used it recently in the office itself, and patients have tolerated it very well. Usually, you know, with plantar fasciitis, or I used it a lot for posterior reticular tendonitis. So once you do that local like PT block or a localized V block around the area, and you use your ultrasound machine, my patients tell me that there is not much pain associated with it, which is nice. Now, cost-wise, this is where you have to do your research, and you have to ask these companies for their studies, because I did look through when I started doing PRP a few years ago, which companies had better studies to back them up. There is a whole bunch of companies carrying PRP right now. And so I don't want to go into certain companies and which is better and those sorts of things, but definitely look at the research. And with shelf life and those different things, so usually they bring in the centrifuge so you can spin the blood right away and inject it into the area. So there isn't anything that you really need to keep on the shelf itself. And if you're doing a lot of PRP in your office monthly, then most of these companies will actually give you the centrifuge, and you can train your staff to do it. The first couple of times it's nice to have the rep come in and spin it for you.
That's wonderful. Thank you, Dr. P, for all of your insights. I want to thank you all for joining us for week 7 of this APMA Online CECH series. This week concludes the current series, but we're very pleased to announce that registration is now open for the APMA Online Summer Series, which will take place Saturday and Sunday, August 8th and 9th for up to 13 CECH, and Saturday and Sunday, August 15th and 16th for up to an additional 12 CECH for a total of 25 CECH if you join us for both weekend sessions. Check out www.apma.org/summer series for the most up-to-date details, including the educational programming, registration fees, and more. Join us this summer for a tremendously affordable program. Thank you all and have a great evening.
Thank you, everyone. Stay safe.